Okay. Good.
Thank you so much, Olivia. And thank you all for having me here. It's a real pleasure and to actually come here and be able to see you in person. So thank you very much. So today I was going to tell you about a trial that we've been conducting in the Scottish Bowel Screening Programme, testing 2 different behavioural interventions. And this work was funded by Cancer Research UK and the Scottish Chief Scientist Office. So these are the 2 behavioural interventions that we were testing. They are additional information that were put within the invitation letters to bowel screening. And one is what we call a planning tool, which is the yellow one on the left. And the other was just simply changing one sentence of the invitation letter to include a suggested deadline. So I'm now going to tell you about how these sort of came about and what we did to develop them, but just to orientate you to that's what we're going to be talking about, and I'll show you the results. So just to provide a bit of context for those of you who may not know that much, which is probably all of you, about cancer screening in Scotland. So we offer breast, cervical, bowel screening, and we're in the process of thinking about how we could do lung. Currently, it feels quite challenging, but there are definitely plans to implement it. And so we're talking today about the bowel screening programme. So what happens in Scotland is you are mailed when you turn 50 the FIT kit, and you're asked to take one sample and then send it back for testing to the Scottish Bowel Screening Centre. And if blood is detected in the sample, then you'll be invited in for a colonoscopy and followed up. So this is Scotland here. At the top of the UK, it is only has a population of 5 million, which I think is actually smaller than the population of Sydney. And we sort of think we have quite a varied geography, because we've got a sort of densely central area towards the south where most people live, and then we have the challenge of our rural communities and our islands and highlands, which just seems sort of almost laughable in comparison to Australia and the vast distances that you cover. So yes, that's where the Scottish Bowel Screening takes place. So like many countries in the world, there is suboptimal participation in the Scottish Bowel Screening Programme. It's actually, since the introduction of the FIT test, which only requires one sample, uptakes now at 67%, which is actually internationally pretty good. But we still see stark inequalities in participation, and this slide shows differences by sex and also by, yes.
Just a quick question on that. Do you know what the increase was to moving from 2 to 1 sample?
Yeah, so it went, I think it was 55%. Okay. So it was a massive increase. It's like bigger than any other intervention that we've seen.
Could we still have the two samples?
So it's a little bit different, because we were using the FOBT stool test, not a FIT. So I know in Australia you use 2 FITs.
Yeah.
So, but I think there's still similarities, and then the barriers of having to store it and just doing it twice and that kind of issue. So yeah, for us, it definitely seems like having a more simple test is vastly improved return of the kits. So this graph just shows the difference in participation by socioeconomic deprivation, and you can see that the people in the most deprived areas, there's a 20% gap between those living in the most deprived compared to the least deprived areas. So although our uptake is pretty good, although it means that still under 1/3 of the population are not participating. Ooh, don't know if that will have serious consequences or not. Yeah, we're still grappling with inequalities in who's actually participating. So the interventions that we tested in the TEMPO trial developed out of qualitative research, where we were trying to understand why bowel screening fails to achieve the same levels of uptake as breast and cervical screening, because in Scotland, women from 50 are invited for all three, and it sort of seems interesting as to why you would screen 2 bits of your body, but not a third. And that led us on to some of these ideas that we then went on to develop. So this is a sample quote. If it's a bowel screening one, yeah, put it somewhere and think, yes, I'll do that, and then forget about it because it doesn't have an appointment date. I think if something has an appointment date, you're forced to act. So in contrast to the bowel screening program, which mails the kits to people's houses, the cervical and breast involve visiting a health clinic and being supported to do the screening by a health professional. This is the integrated screening action model, and we integrated our qualitative findings with our understanding of screening behaviour from both the theoretical literature and the empirical literature. And the ISAM model basically tries to give a summary of our theoretical and empirical understanding of screening behaviour. And it's based on the central section, the screening behaviour process, is based on Neil Weinstein's precaution adoption process model, which basically says that depending on where you are in the screening process, you might need to have different types of interventions. So some people may be completely unaware that screening even exists, whereas someone else might be, they know it exists, but they're a bit undecided, or they've actually decided to act, but aren't quite getting round to it, as that previous quote suggested. The other aspects of the model are that both participant influences and environmental influences will determine whether somebody engages with screening or not. And we also, or I included the Susan Michi's COM-B model, so that's the capability, opportunity, and motivation aspects of behaviour. And then within each of those, the motivation, capability, and opportunity, there's targets for intervention based on what we know from the empirical literature has been associated with screening behaviour. And so it will be an iterative process to see how useful the ISAM is, but it's certainly provided us with a bit of a structure for trying to understand all that's going on in screening behaviour. So the 2 interventions that we were testing, we were focusing on this group of people, sometimes described as, yeah, so the interventions were specifically targeted on people who we thought were motivated to do screening, so they wanted to do screening, but maybe weren't quite getting around to it. And it's very well acknowledged within the behavioural science literature that there's this intention behaviour gap. And Pascal Sheeran and Sheena Orbell have described inclined abstainers. So we wanted to try and target our interventions at this group of people specifically. And so what we did was I'll just move that there. We developed a planning support tool and the deadline to target sort of action planning, behaviour and goal setting. And the planning support was based on work that Chris Armitage has done, looking at providing what he describes as a volitional help sheet, which I felt was too complicated, so I called it planning support or planning tool. And it's this idea that you present people with what they see as the sort of barriers to doing the behaviour, and then give them solutions, and they have to physically draw a line with a pen or a pencil between what they see the barriers being and what a solution could be. And there's been evidence that this has been effective in smoking cessation and increasing physical activity and dietary behaviour. So we were interested to see if it would work within the bowel screening context. So in developing the planning tool, we conducted a series of studies. We started off by interviewing people, both who had participated in the bowel screening programme and people who hadn't, and we asked them about what the barriers were and what the solutions were. And then we conducted a survey to try and quantify what the most common types of barriers were and then what the solutions were. And then we did co-design workshops with people who had both done bowel screening and who hadn't, and from a range of different socioeconomic backgrounds, to help create a user-friendly planning tool. And this is what the final planning tool looks like. So you'll see it says, here are some tips that people find helpful to make bowel screening even easier. Try drawing a line from any concern you have with a tip. There are no right or wrong answers. And so the concerns were derived from the qualitative and quantitative survey that we'd conducted. So, for example, the top one is, if I feel scared about bowel screening, and the idea is that from that you try and link it to a potential solution or tip, then I'll think that this kit could help save my life, for example. And we came up with our own prototype planning tool, which looked absolutely nothing like this. Well, it did have 2 columns, but through the co-design, this is where we ended up, and they wanted it bright yellow so that it would stand out from the other information that they were being sent. And they also had the opportunity, if one of their concern wasn't there, that they could add their own one at the bottom and a potential solution. So this was sent with the invitation letter, with the kit, as something to help support their planning of doing it. The deadline intervention was much more simple to develop. All we did was add 1 sentence to the invitation letter, which was, please return your kit within 4 weeks. We also tested 2 weeks and 1 week. And we gave them what that date was and said, or as soon as possible. We randomised people to one of 8 groups within the Scottish Bowel Screening Programme. So we randomised 40,000 people, and we had a control group. We gave one group a 1-week deadline. Did you want to ask some questions? No, you're just looking encouragingly at me. Okay.
1,000 people is so many people. It's huge.
Yeah.
It is, but that's the wonderful thing about doing something in a screening programme, because that only took about 2 weeks. So,
Yeah.
so our statistician was just like, I was thinking it would take 10 years compared to the trials that he's usually involved with.
Okay, Katie, if you want to get rid of the Zoom bar,
Yeah.
that line, you click on that little line in
Like
the
the
top
there.
right, that's one there.
Ah, perfect. Okay. Yes, so people were randomized to these different groups, 1 week, 2 week, 4 week deadline, or the planning tool by itself. And then we were interested to see the interaction between the 2 different interventions. So then some people got a planning tool plus a 1 week deadline, a 2 week deadline, and a 4 week deadline. And this, yeah. And these are the results. Quite interesting results, surprising results, but at least some things happened, because that was our biggest, or my biggest view, so it would make no difference. So in the control group, fit kit return was 66%. If you gave a 1 week deadline, it didn't make a difference. If you gave a 2 week deadline, it increased fit return by 1.9%. 4 week deadline, it was 0.8%. Really surprisingly, is if you gave a planning tool by itself without a deadline, it was detrimental to kit return. It reduced kit return by minus 2.8%. But if given in combination with a 1 week deadline, it was 1.8%, with a 2 week deadline, it was 1.7%, and the 4 week deadline, it was 1.1%. So really surprising, or maybe not surprising, depending on what you might have predicted, but surprising to us set of findings that's taken us a while to try and get our head round. This is the multivariable analysis. So in model 1, what we see is there was a significant difference of including any type of deadline. So the odds were 1.13. But if we gave a planning tool, it didn't change return of kits. There was a significant interaction between the two interventions. So if you give a deadline with a planning tool, it actually enhanced the impact of the deadline, and the odds were 1.21. But the planning tool with no deadline was certainly detrimental, and you see the odds are 0.88. We also conducted a survey after people had been sent the interventions to see to assess people's acceptability of the different interventions, and overall both were perceived to be acceptable. And this one asked about the planning tool, and about 80% of people thought it was acceptable. And then we measured different aspects of acceptability using the acceptability framework that Randy Second has developed. And then we also conducted interviews with people to try and get their views on what they felt or how they perceived the interventions. And so this person who'd received a planning tool said, I think it's fair, because if you do have concerns, or you know that they might think, well, it's maybe just me that thinks like this, but if they can read that, perhaps it might be a general concern for folk, or to have tips to help them, it might reassure them a bit that they're not alone, and it's not an uncommon feeling to feel like that when you're doing the test. These are the acceptability data for the deadline. So it was about 87% of people felt it was an acceptable type of intervention. So a little bit more than the planning tool, but not drastically. And this is somebody who received a 1-week deadline. I think at the time I probably thought, I wonder why they put a time scale on it. Do you know what I mean? Like thinking, why is that? And that probably crossed my mind. And then maybe feeling a wee bit tiny panicky, thinking, oh God, I better get this done. Do you know what I mean? So in conclusion, what we saw with the 2-week deadline was a 1.9% increase in kit return. And that may seem that not a big effect, but because it's done at a population level within the screening programme, that means within the Scottish bowel screening programme, 34,000 additional people participating in a 2-year round. And we estimate that to mean that 20 lives could be saved. And then if you multiplied it up to the UK population, that would be 268 lives saved, which, given all we're doing is changing one sentence in the invitation letter, it's very effective, I think. There was a big team of us who worked on this study, and I acknowledge all of those people, and also to Cancer Research UK and the Scottish Chief Scientist Office for funding it. Thank you.
Can I start? Can I ask the first question?
Just when you ask, I just want to double check that people can hear.
Okay. So the question is, did you look at those results by deprivation?
Yes, sorry, I forgot to say that.
People online, could you hear Kirsten's question?
Yeah, we can hear you.
Awesome.
Shall I stop sharing it? Yeah. Okay. Yeah, I need to include a slide because I always forget to say that. So we saw no interactions by any of the demographic factors that we had. So we had sex, age, Scottish Index of Multiple Deprivation, and rural urban area. So I think ideally I would have liked to see some reduction, or that would be more beneficial in the more deprived areas. But actually, I think the fact that it didn't exacerbate inequalities is a good thing. I guess it raised, they were equally effective across socioeconomic groups, or across all demographic groups, which is good. But in our efforts to try and reduce inequalities, I think the only thing that we could do would be to target deadlines at particular postcodes. And I don't know how ethical that could be if what we were trying to do is reduce the gap.
Wondering if you could add like a phone call. I don't know what the costs of that would be, like a reminder phone call.
Phone call to particular
to, anyway, I don't know what the logistics of that
Yeah.
is.
Yeah, and we were interested because this is obviously delivered by letter, and we don't know what the impact would be if we sent like a text reminder and that's the thing, or the deadline within a
Yeah.
text message. So that's something else that we could potentially look at.
So it's a great study.
Any other questions?
Are they doing it? No?
They not yet. So we're about to submit the paper for publication. So we don't know how long that's going to take, how that goes. And so I sort of feel a bit hesitant about them doing anything until it's been sort of properly peer reviewed. But the Scottish Bowel Screening Programme have obviously been very involved in helping us to do the trial, so they're aware of the results and they are really keen to implement it. But they I think they seem like they do want to do it, and they probably will do it, but we're not there yet. So because it seems such a simple change to make. But I suppose a challenge is that our colonoscopy capacity is so under strain. So there's actually, although on the one hand we want to improve the numbers of people returning their kits, actually further down the line, do we have the colonoscopy capacity? So I actually got a lot of pushback when I was trying to set up the trial from the health boards across Scotland, because they're so at capacity already with their colonoscopy, and I think they were terrified that it'd actually have a lot bigger impact than it did, and so they'd be swamped with colonoscopies. So this is actually.
And is that just from the programme? Is that more pressure from the programme from the colonoscopies, or is that people kind of being,
It's both. It's both. It's just there's a sort of shortage of people doing colonoscopy or capacity to complete the colonoscopies.
Question online.
Okay.
Did you say I could ask my question online?
Yes.
Oh, okay. You can hear me okay? Okay. Hi, Katie. Thank you so much for that presentation. It was really interesting. Just following on from your comment about working with the different health boards, there has been some attempts to try and initiate something like this with the Australian program, and it hasn't quite got off the ground. I was wondering if there was any advice on how you managed to do this, because it is indeed quite impressive, and I guess what the selling points were from a system perspective, or any insights you might have. Thanks.
Yeah, no, that's a really important question because it was really challenging to do. And I think it comes down to individual people and their roles and their relationships. So the study, one of our co-investigators is Professor Bob Steele, who helped set up the Scottish Bowel Screening Programme. He's just retired actually, but he was the clinical lead for bowel screening. So he's always been very open to research and was very supportive of the study. And he was also the chair of the UK National Screening Committee. So a very sort of well-regarded person who was sort of endorsing and supporting this study. But it was difficult, and it's not it became slightly because there was so much resistance from the health boards that they wanted to stop the trial. And to me, I think I'm quite naive to all of that, and it didn't seem clear to me then who got to decide. And I don't think there is one person who gets to decide whether something should go ahead or not, because the Chief Scientist's Office, which is funded by the Scottish Government, had funded part of it, so that it had been sort of approved from that perspective. But then if the NHS boards were saying, no, we don't want this, and so we just kind of, I don't even know how it came about. I think people sort of calmed down, and then we proceeded, and so I don't actually, I completely understand why there could be challenges within Australia on this, because that's exactly what we experienced too. And I think it is about building up these relationships, or having the sort of trusted people who will support it, because I think people are really resistant to change, and to making any changes to the system. But yeah, I don't think I've got a very good answer.
No, I think it's
Or
really
solution.
No, I think it was really encouraging to hear you kind of describe the process, because I don't know, you know, you think other people might have it easier. It's not always that easy.
Yeah.
Yeah. I did have another question, if that's okay.
Yeah, of course.
Just in terms of the results, was there any analysis done by age group, and whether the interventions work differently by the different age groups or by sex at all?
There were no interactions by any of the demographic groups that we had. So we had age, sex, Scottish Index, multiple deprivation, and rural urban classification, and there were no interactions. So they were equally effective or ineffective across all groups equally, which was quite interesting, because I sort of thought, oh, maybe if you're just being invited for the first time, one or other of the interventions would be more useful, but we didn't see that in the data.
Ask another question, just a bit related to that. Did you see if there are any differences in acceptability of the planning tool? I mean, I'm really interested in the planning tool. You know, was a bit effective, but obviously one would have hoped it would be more effective. Was there any insights, if you look at predictors?
Yeah.
What was the acceptability on those items there?
So we are currently still in the process of doing that data analysis. So that is something that we can look at both. Yeah, because we've got the survey data, and then we've also got the qualitative interview data as well. So possibly, but we don't know yet. So we're still looking at that.
Thinking of Julie's your planning tool.
Mm-hmm.
Like, I think, and I'm probably remembering this wrongly, but individualizing your plan seems quite valuable. And in that tool, were people able to individualize? So you made up your own if then I do X. And so on your tool, because it was obviously printed, you can't, you don't have that flexibility. So I wondered if there's a way of enabling people to tailor it to their particular circumstance, whether that helps its usability in planning tools. You need to have that feature.
Yes, possibly. Although I think the ones that Chris Armitage did, they were already set up in their volitional help sheets.
And they
worked in those other contexts. Yeah. But I've seen, so Daryl O'Connor, who's at Leeds, did a study in the northeast of England, or the north of England, and he found that the volitional help sheet, planning sheet that he developed was ineffective as well. But there was a study done in Israel where it was effective, but they had the instruction at the start of it of doing it like set when you are going to do this. So it's sort of like prompting them to set a deadline anyway of when they should do it, and then they were to do the if then things.
So when they were going to do the action.
Yeah. And so that made me think, oh, actually that's more comparable with when we gave her a deadline plus the planning tool, and actually then that was effective. So maybe if given, if you try and get them to set their own deadline,
to do the
test.
and identify the barriers.
What was that for screening behaviours, or were those for?
They were screening behaviours. Yeah, they were bowel screening.
So one of the other things I would say is that the volitional help sheets were kind of based on a habit changing model, whereas screening behaviour is like a discrete one. And I think to me, it makes sense that it's because having a deadline is kind of a blend of an action plan where you say when, where, how many times, whatever, and which you can do for these discrete ones versus something that's more focused on. The original research is more focused on habit, but it's obviously still working for a group of people as well.
Yeah.
I really like the comment as well about it normalizing the experience for people. I think that's really interesting. I haven't seen that in relational help sheet.
Oh, okay. Yeah, we're still in an early phase of trying to analyze that data, and because it was collected a bit after. So yeah, it will be interesting to see if more comes out of that.
I feel like you should do another trial, Katie.
What do you want me to test?
Well, we need to put in, I'm gonna say when I'm
Yeah.
gonna do the kit on this day, and I'm gonna think about the barriers. Anyway, you could another 40.
So you want to keep pursuing the planning tool, the volitional help sheet idea?
I reckon you could tweak that with the 2 week deadline.
Yeah.
And
That's
make
good.
it sort of.
Yeah, no, one of our, because we were all a bit doom and gloom about the impact of the planning tool. But one of our co-investigators, Colin McCown, was saying, it's just this one didn't work. This version didn't work. But then, it doesn't mean we can never use like any type of version. And it's true, it's this tweaking or.
I guess it might be more difficult to get that through. To get another trial going, that sounds like there's resistance to start with.
Yeah, but then I kind of feel that having done it once, they might, they might be, and also because I think they were quite excited that the deadline worked, so maybe they can see the benefit in doing these trials. Whereas I feel like if nothing had happened or they'd both been detrimental, I would never be able to do anything ever again within the Scottish Bowel Screening Programme. So,
but it would be really interesting to dig in and also find out for the people with high levels of deprivation, what the barriers are, what the real barriers are.
yeah,
Obviously, we're not really addressing those. With this.
Has there been any kind of trials or anything suggested to kind of try and, because obviously we know with the other screening programs that go into practitioner, it seems to, obviously the participation rates are higher. About kind of, has there been anything done about trying to get maybe offering it in primary care, or is there a way of kind of involving the practitioner for some of those like most deprived? I mean, I know there's other barriers in terms of being getting to that.
yeah, and I mean that has that study that I referred to where we were comparing 3 different screening programs. People would say, yeah, I just like a bit more help, and the practicalities are quite tricky because it sort of depends on when you need to go to the toilet, so that you have your sample. So I think that is challenging. I think what's going to be interesting with the cervical self-sampling coming in, sort of looking, I'm just talking broadly, like what that does, and if it becomes more comparable to doing bowel screening, or if it's still quite different. But I think there's sort of a belief that being able to self-sample is going to be a big benefit, but based on the comparison with doing a self-sample stool test, that seems to decrease participation. So yeah, I don't know. We shall see, but yeah, lots of interesting behavioural things to still.
And hey, can I ask just one final question? How did you manage ethics for it?
So the ethics was really smooth actually. So it was just approved.
Individual informed?
No. So they weren't aware that they were in a study at all. Yeah. So it was just approved by the ethics committee that they would be randomised, and they wouldn't know. Yeah. Because that would have, and then when we were trying to get the protocol paper published, there was the reviewers were sort of not pushing back, but wanting more justification for that. But it just would be unworkable because you'd then get to such a selected sample. of people who are willing to participate. So I suppose that is one strength, that the ethics committees are willing to support that type of approach.
We look forward to the next trial.
Feeling quite old by then, I think.
How long did it take from the kind of start, you know?
Well, the pandemic didn't help. I think so. We started off first with the planning tool was funded by the Chief Scientist's Office, and the deadline was funded by the Cancer Research Team. And I initially thought I was going to do them just as separate trials, but then everyone was so horrified by the idea of doing anything in the program that we stuck them together, which was actually made much better design, because then we were able to do this factorial comparison. I think we started in 2017 with the planning tool, and then the deadline, I think that study, I mean, that was a small study. It was only for like 15 months or 18 months or something, which is an amazing investment from CR, or an amazing return for CR UK, that it was just such a small thing that's really impactful. And then we were meant to do the trial in 2020. So that wouldn't have been that long, actually, say like 3 years or something. But then the pandemic, we were meant to do April 2020, but then we couldn't. And then it was really challenging, because we were running out of money, because we were having to still pay, well, there was the furloughing, but then we had to, we were waiting for the bowel screening program to get up and running again, because it had been completely stopped, and we thought we were going to run out of money before we could even do the trial, but somehow it all got there in the end. So it was a huge relief.
And hey, that does the sort of the timing about the finding of the timing of the deadline, so the 2 weeks being optimal versus 4 weeks or 3 weeks is actually a very useful finding for many health
that's true,
contexts,
actually.
having many implications.
I was stressing that 1 week was obviously just too short.
1 week's too short, but 2 weeks is the sort of sweet spot. So you know, in your implications, that's huge. You know, hugely useful. So, are there any more questions online?
If there's no more questions, I'll wrap up. Thank you everyone for joining, and thank you so much for Katie making
Thank you
time
very
to
much
visit
for
us.
having me. What a delight.